Hello and good day. So today we're going to talk about your critical care nursing, and it's all about your respiratory. So most likely you already have a background of the anatomy and physiology of your respiratory system so that we can already skip that part. However, I want you to go over again in your book on your anatomy and physiology manual so that you can be familiarized again with the parts as well as the functions of your respiration. Okay, and with that, we will be starting with this one, the history taking of the client with critical care in terms of your respiration or respiratory system. So the first one is all about your chief complaint. And of course, if we cannot gather primary information from our client, we will be going to the significant others, and we're going also to gather information about the history of the present illness, as well as the past health history, the family history, the personal and social history if the patient is, a smoker or, frequently using vape for recreation, and as well as the review of the system. So most likely this kind of assessment, you've already learned this one on your second semester in your first year level. Now let's go here. So if we talk about your chief complaint, the first thing or most likely you've encountered patients with respiratory disease or disorder or illness, patient experiencing dyspnea. Now, if the patient is occurring lying flat, most likely the patient is experiencing your orthopnea. Okay. And if the patient is awakened at night, that is what we term as your PND or your paroxysmal nocturnal dyspnea. And we are all aware that, this is a sensation of SOB that usually awakens the patient often after 1 or 2 hours of sleep, and we can relieve this kind of difficulty of breathing by making our patient or positioning our patient in upright. Okay, there are also exacerbating factors, the length of episodes and any relief measured attempted, as well as often signify heart failure, but may occur in a variety of your pulmonary disorders. Now here, um, chest pain. The anterior chest pain discomfort must be distinguished from your angina. This one we've already tackled from the previous term about your cardio disease. This will also determine whether the patient experiences more than one type of pain, and ask the patient to describe the pain using the mnemonic NOPQRST. Now let's move on here. So aside from having your subjective data, we can also gather your objective data by properly observing the sputum production of our client. Now, the amount and the color produced usually is in 24 hours, and the color comes from your WBC in the sputum. Now, as you can see here in this illustration, different types or different colors varied in terms of your sputum. Now, if it's whitish in color, usually there's an absence of bacterial infection. However, if it's yellowish, there's production of many eosinophils, thereby sometimes signify some allergy reactions. If it's rust-colored yellowish sputum mixed with blood, usually this is some sort of your tuberculosis. While if it's mucoid or viscid or blood streak, typically this kind of sputum is viral infection. Okay, how about with the large amount of clotted blood? Usually this is suffered from your pulmonary infarction. Okay, now let's move on here. How about your cough? Well, predominantly these are the symptoms that we usually um, observe to our clients with respiratory problems, which is the cough. So, frequent respiratory symptom with varying significance, now, such as external agents, inflammation of your respiratory mucosa, or pressure on an airway caused by a tumor may stimulate a cough. Sometimes smoking, allergies, heartburn, asthma, and certain medications, including your angiotensin converting enzyme inhibitors and B blockers, they may cause cough. So, with your thorough observation and with your assessment, you can actually detect what are the causative agent or what are the causes while patient is having frequent cough. Now let's move on here. How about the physical examination of the client? So while inspecting the client, sometimes you may observe that the client may have your cyanosis. We already know this term. This is the bluish discoloration of the skin or the mucous membrane. So difficult to detect in a patient with your anemia because they're very whitish. We have two types. We've learned this one already, which is your peripheral as well as your cyanosis. So if you say peripheral cyanosis from the term itself, from the peripheries of our body in our fingers and our feet, while the central cyanosis is in the central part of our body. Okay. Now moving on to the next one. So we have the labored breathing. This is the marker of your respiratory distress using the accessory muscle for the respiration. So if you say your accessory muscles in terms of respiration, they are your scalene and your sternocleidoid muscles, the one that we are actually utilizing, in order for us to breathe properly. You also have your intercostal retraction. This is the sucking in of the muscles and the skin between the ribs during your inspiration. Okay. The next one here, we have this term that what we call as your staccato speech, wherein the patient's speech pattern is frequently interrupted as he or she gulps for air, then may accompany labored breathing. And then we also have your anterior posterior diameter of the chest is in overexpansion of the lung from your obstructive pulmonary diseases. We also have your kyphosis, or some in our local term, which is the kuba. This is the curvature of the spine. We also have an increase of your anterior posterior diameter. In terms of your physical examination continuation, we have your chest deformities and scars, and you always notice this one with the patients who have COPD. This is like their comfort, the most comfortable position. The sit and drop up out on stretched arms or lean forward with their elbows on a table in an effort to elevate their clavicle. This gives the client a slightly greater ability to expand their chest. This kind of position, again, is very typical to patients with your COPD. Your inspection position of the trachea, midline or deviated off to one side. Also have pleural effusion, hemothorax, pneumothorax, tension pneumothorax can deviate the trachea away from the affected side toward the opposite side. Now, the atelectasis, you already know this term, the lung collapse, fibrosis, and phrenic nerve paralysis often pull the trachea toward the affected side. Okay, so that's the difference. Your atelectasis, fibrosis, and phrenic nerve paralysis pull the trachea toward the affected side, while your pleural effusion, pneumothorax, hemothorax, tension pneumothorax can deviate the trachea away from the affected side. How about this one in terms of your respiratory rate? Now, should be counted over at least 15-second period for stable patient, and over a full minute for critically ill. But technically speaking, we should always count the respiration in full 60 seconds or 1 minute. And with this one, the normal is 12 to 20 for adults. Breathing 24 to 26 times a minute may be normal in one patient but abnormal in another. So it varies. The respiratory effort, like example, is your Kussmaul's respiration in diabetic acidosis. Duration and inspiration versus duration of expiration helps determine the presence of your obstructive lung diseases. Now, expiration is more than 1.5 times long as inspiration with many or with any of obstructive lung diseases. Moving on here, we also have your thoracic expansion. Normally at inches occur from maximal expiration to maximal inspiration. Also have your clapping of fingers, which is brought to you by chronic hypoxia. And palpation, we have your tactile primitus. This is the ability to feel the sound of the chest wall. So you can see here in our illustration, just like this one. So ask the patient to say 99 while moving hand over the posterior surface of the chest wall. Okay, so this is the proper lung assessment. So in order for you to properly hear or listen to the lung sound, so just follow this sequence from here to here, down to here, down to, and so on and so forth. Now, most likely during the auscultation period of your assessment, you will be hearing 3 types of sounds, like your basic breathing sounds, the adventitious lung sound, and the additional sound samples. So we have your normal breathing, vesicular breathing, bronchovesicular, and your bronchial, and the like. So we're going to differentiate them one by one here. Now, if we say your vesicular sounds, they are usually soft, blowing, or rustling sounds that normally heard throughout most of your lung field. While your bronchovesicular, from the term itself, broncho, from the bronchial area, and then the vesicular area, they are present over the large airways in the anterior part of your chest near your second and third intercostal spaces. Okay, so in terms of characteristics of this one, your bronchial sounds are high in pitch, and also louder and more tubular or hollow sounding than vesicular sounds, but they are not as harsh as your tracheal breath sounds. Your bronchovesicular, a while ago it's all about your bronchial sounds. This time, this is your bronchovesicular, from your bronchial and your vesicular area. They are heard in the posterior chest between your scapulae and in the center part of your anterior chest. So this is more of softer than bronchial sounds, but have a tubular quality. While your tracheal, of course, they are heard over your trachea, and these sounds are harsh and sounds like air is being blown through a pipe. Now, in terms of your abnormal breath sounds, most likely you all are already familiar with this one. We have your wheezing, your fine crackles, your coarse crackles, your squawks, or your pleural rub. You also have your stridor. These things, I know that you are very familiar with this one already. So just go on and read this abnormal breath sounds. Okay. Now here, the friction rub is crackling, grating sound heard more often with inspiration than your expiration. Results were in the vesicular and parietal pleural rubbing against each other. It stops when breathing also stops. And we also have your pericardial friction rub continues while the patient is still holding his or her breath. Now, so here, these are your landmarks in order for you to properly hear and differentiate your vesicular, bronchovesicular, and bronchial, and also your tracheal lung sounds. Respiratory monitoring. This one you've seen most likely this kind of apparatus or equipment in the ICU or in the emergency room wherein we are using your pulse oximeter. Okay, so this is the accurate blood oxygen saturation and pulse rate reading, and the information will help you monitor the condition during exercise, activities of daily living, or air travel. So definitely from 95 to 100%, this is the normal blood oxygen level. However, if you detected lower than 95, that's the time that you will be having a concern. So you will be start checking the capillary refill or checking if it's properly placed in the fingertip of our clients. If it's okay and it's still going down to less than 90%, there's already low blood oxygen level. That's the time that you can start your oxygen therapy. And when the low oxygen saturation affects your brain, that is already from 80 to 85, and there's already cyanosis if it's already 67%. Okay, now let's go here. One of the important also that you're going to learn in your emergency room or in the medical or in the ICU is your ABG analysis or your arterial blood gas. So this is the sample of arterial blood is drawn and analyzed to help determine the quality and extent of your pulmonary gas exchange and your acid base status. One of the easiest way in order for you to know or properly calculate this one is to familiarize yourself with the normal values of the pH of your carbon dioxide, of your bicarbonate, as well as if it's normal or abnormal, or if it's respiratory or metabolic. So if in terms of the pH of the blood, it's 7.35 to 7.45. Lower than your 7.35 is your acidic, and higher than 7.45 it is alkaline. While your carbon dioxide is the range is 35 to 45, and your bicarbonate is 22 to 26. The first thing that you're going to determine here is, of course, the pH of the blood. Once you determine the pH of the blood, you can already know if it's acidic or alkaline. Okay, and then after which you're going to identify the respiratory, or if it's metabolic, then you need to compare it to the pH. For example, of this one, you have your pH of 7.96, that is already alkalosis, and your carbon dioxide, that is 29, that is basic. And here you also have your bicarbonate, which is 22. This one is in your normal range. So if your bicarbonate here, your bicarbonate is normal, while your carbon dioxide, which is your PaCO2, which is 29, that is abnormal, that is considered as respiratory. And again, let's go back to the pH. The pH is alkalosis, so this one is respiratory alkalosis. Now, how about this one? The pH is elevated, which is 7.54. This is alkaline. And then your bicarbonate is 23, that is normal range, but your carbon dioxide is 26, that is also abnormal. So this one will also fall under your respiratory alkalosis. How about the next one here? The pH of 7.3. So this one is acidic, and your um, carbon dioxide is 80. This is way high, and your bicarbonate is 26. This is normal. So if you're going to look at this one, we have an abnormal, we have your abnormal carbon dioxide, but we have normal bicarbonate to 26, and your pH is acidic. So this one is respiratory acidosis. So that one. So I hope you've learned that part. You will do a lot of that in your laboratory as well as in your duties in your ICU. So in terms of diagnosing, we have your chest radiography, of course, your chest x-ray. We have your ventilation perfusion scanning. So with this one, this is under your nuclear imaging test. How about this one? Pulmonary angiography. In your pulmonary angiography, this involves the rapid injection of your radiopaque substance in order for the radiographic studies of the pulmonary vasculature. So you can see here. Okay, so this one usually symbolizes pulmonary embolus. Bronchoscopy, you're already familiar with this one. This is the direct visualization of the larynx, of the trachea, and the bronchi through the flexible fiber optic bronchoscope. So you can see there. And it's usually used in diagnosing or to examine tissues, collect secretions, determine the extent and location of your pathologic process, and of course to obtain a biopsy. Okay, so therapeutically, to remove foreign bodies or secretions from a threat of your post-operation atelectasis, and of course to excise your lesions. Thoracentesis, this one can actually be done in the bedside, in the OPD, or in the ER. So this one is a needle is being inserted in the pleural space to remove air, fluid, or sometimes both, as you can see here on our illustration. So the patient sitting upright and leaning slightly toward with the arms supported. Now here, as nurses, what you're going to do is you're going to monitor the patient's symptoms and blood pressure and stop the drainage if the patient develops chest pain, dyspnea, or hypotension. Okay. Sputum culture, we've talked about this one a while ago. Culture and sensitivity, cytology, and acid fast bacilli pulmonary function test. I don't know if this is available in the Philippines or here in Pangasinan. Measures of pulmonary anatomy, volume measurement capacity, measures and dynamic measurements. Patient management, we usually write this one in our nursing care plan or instruct this one to our clients in the bedside, coughing and breathing exercise or deep breathing exercise. We also do your chest physiotherapy, especially if you just finished doing your nebulization, so that you can clog, you can declog secretions in the lung area, postural drainage, chest percussion and vibration, and of course, patient positioning, so that the patient can actually expel the secretions inside their bodies. We also have your patient management. Your oxygen therapy is designed to correct your hypoxemia as well as your hypoxia. Your hypoxemia is low oxygen blood level when tissue oxygen availability is decreased, While your hypoxia is decrease of oxygen supply, which can be generalized or region limited. For example, is tissue hypoxia. Okay? Now, oxygen therapy corrects hypoxemia, decrease the work of breathing, and decreases myocardial work. Any disease process that alters the gas exchange can cause your hypoxemia. We also have here the level of consciousness or the LOC of the client. So this is the term used to describe a person's awareness and understanding to what is happening in his or her surroundings. So we can actually, categorize this one in three main levels. You have your consciousness, your decreased consciousness, as well as the patient is being unconscious. Okay. So I hope you know these three main level of your consciousness. So if you say consciousness, of course the patient is awake, the patient is aware. You can actually converse with the client, you can talk, the patient responds normally. If there's a decrease in consciousness, the person appears to be awake and aware of the surrounding but is not actually responding normally. Sometimes the way they talk is gibberish, and they were like saying words that you cannot really comprehend. Okay, and unconscious, of course, the patient is asleep, or they were not able to respond, and they are not aware of what is happening. The vital signs, also the nail bed color, your capillary refill, airway patency or presence of your artificial airway, your ABGs, SaO2, and the use of your accessory muscle of your abdominal breathing. Laboratory data, just read this part on the PowerPoint that I sent to you. Complications of your oxygen therapy, just read this part. Oxygen therapy, we have your low flow oxygen and the high flow oxygen. Of course, from the term itself, if we say low flow oxygen, devices work by supplying oxygen at a flow rate less than the patient's inspiratory volume. So usually here we're giving at least 1 to 10 liters per minute. Okay, so this is quite suitable for patient with normal respiratory patterns, rate, and ventilation volume. On the other hand, your high flow oxygen, this one is usually 1 to 40 liters per minute. And this is suitable for patients with high oxygen requirements because high flow devices deliver 100% oxygen and maintains 100% humidification. With that, we have here your nasal cannula. So can be used even when the mouth with mouth breathers because oxygen fills your nasopharynx. A simple calculation for your nasal cannula is to add another 4% to each of your FiO2 delivered to the ear of 21. Like 1 is 21 to 25%, and flow rate of 2 liters per minute, you will just add 4, so it will become 25 to 28, and 28 to 32, and so on. While your face mask here, 5 to 6 will equate to 40%, 6 to 7 is 50%, and 7 to 8 is 60%. Well, this one, your Venturi mask, this is the oxygen concentration is constant and delivers an exact percentage of your oxygen. Flow 4 is 25, 5 is 28, 6 is 31, and so on. So here are the other examples or the other illustrations wherein you can use your they are being used for oxygen therapy. While the COPD patient may require oxygen by Venturi mask. Now, these patients are sensitive to oxygen, and a small increase in the percentage of your FiO2 delivered may result elevated carbon dioxide and also respiratory depression. How about this one? Artificial airway. So we have your fourfold purposes: establishment of an airway, protection of airway with a cap inflated, provision of continuous ventilator assistance with ETT and tracheostomy, and facilitation of your airway clearance. The first one here is we have your OPA. This is your oropharyngeal airway. Now, as you can see, maybe you've observed this one in the ER or ICU already. This one is never placed in a patient who is conscious. It's because with the reason that it can actually stimulate your gag reflex, and if our gag reflex is being stimulated, of course it's very difficult to insert your oropharyngeal airway. It's because it can sometimes cause vomiting or aspiration. Okay, now your OPA is an airway adjunct used to maintain or open the airway by stopping the tongue from the covering your epiglottis. In this position, the tongue may prevent an individual from breathing. So aside from your OPA, we also have your NPA or your nasopharyngeal airway. Now with this one, this is potential for epistaxis with the removal of your NPA. So we have to, we have to be aware of that. And with this one, an oxygen mask or bag mask of ventilation can actually be applied over the top if it's really needed. Okay. So with this one, your nasopharyngeal airway, it can actually be used with patients who are conscious or semi-conscious. For example, if semi-conscious patient may need an NPA because they are at risk for the airway obstruction, but that cannot have your OPA, because your OPA, again, it will ignite or it will stimulate your gag reflex. How about your ETT? With this one, prior to insertion, of course, you really need to check and prepare all the equipment needed with this one. And your ET tube is placed when the patient is unable to breathe on their own. If it's necessary to sedate and rest someone who is very ill, someone's airway needs to be protected. And your ET or endotracheal intubation is often used during the surgery and in a variety of emergency situations. Okay. So here are examples of your naso and oro that are needed to your client. Okay, sectioning. Maybe this one you've done this one. You've already performed this one in your hospital rotation, which is the sectioning. Of course, this one is used to clear the airway of our client. With this one, you really need to properly check if your client is geriatric or pediatric, so that you will know who have fragile airways. Patients with cognitive or mental health condition that make it more difficult or understand the procedure and also to cooperate. We also need to be well aware if the patient is wearing dentures or having a loose dental hardware. Those with a difficult airway or history of suctioning complication as well. and other things that we really need to conduct first to assess the risk for the client. Next one is we have your CT tube. Okay, you've seen this one maybe in the ward. So what's the purpose of your chest tube or your CT? This is to remove the air, the fluid or blood from your pleural space, and to restore the negative pressure to the pleural space, as well as to re-expand a collapsed or partially collapsed lung from pneumothorax, and then prevent reflux or drainage back to your chest. Now, with this one, you must be alerted if there's like a leakage of air into the drainage system, whether in a simple water seal or the mechanical suction type. This is indicated by constant bubbling in the water seal system or bottle. After the client lung initially have been expanded, there will be bubbling in the control bottle, that the one connected to suction. Okay, if there are like air leaks, at the chest tube side in connection in the bottles or in the stoppers in the tree section or in the closed drainage system, you just be very aware of those things. Okay. Now, how about the next one, which is your two-chamber system? As you can see here, the first collection receptacle, and then the second one here, this is the water seal, which has actually your vent. This is the negative pressure. We also have here your chest tube, your three-chamber system or three bottle system. We have your manometer, which is the third bottle. This is added after your underwater seal bottle. Okay. Now here, in terms of your chest tube placement, so this is usually in the second ICS mid-clavicular line. This is the air removal. Fifth or sixth ICS mid-axillary line, this is usually for liquid drainage. Okay, and how should the patient be managed after the insertion of your chest drain? Of course, all connections should be secured, and it can sometimes you have to properly tape it. Chest X-ray should be done so that we can properly assess if the placements are correct, and also patients should be managed in a ward. After the insertion of this one, you should check properly the vital signs and the management of the chest drains as well. So regular assessment of the amount of bubbling when it is gas, and drainage, of course, when it is a liquid, should be properly managed. We have here your pharmacological agents. We have your bronchodilators. So there are type of medication that make our breathing easier by relaxing our muscles in the lungs and widening our airways in the bronchial area of our lungs as well. Okay, so they're often used to treat long-term conditions where the airway may become narrow and inflamed, such as your asthma as well as your COPD. Okay, so here we have your adrenergic agonist as well as your anticholinergic agent. So in terms of your beta-2 adrenergic agonist, this is the mainstay treatment for patients who have asthma actually, and also your COPD. Your anticholinergic agent, this actually blocks your acetylcholine from binding to its receptor on certain nerve cells, and they inhibit action called your parasympathetic nerve impulse, and with that, the nerve impulses are the one who are responsible for involuntary muscle movement into your lungs. And if there are movement or impulses in the lungs, it can actually stimulate more mucus secretions. Okay. We also have here your methicantines, like your theophylline and your aminophylline. These are used for asthma, COPD, lung conditions. You also have your anti-inflammatory, your corticosteroid mast cell stabilizers, and your leukotriene receptors, and of course your antibiotics. Okay, how about this one? Your ventilatory support or ventilator modes or your mech vent. These are support means the patient is on the machine that actually help them to breathe. Okay, of course, it's because they can breathe properly on their own. Now, what is happening here is a tube is put in through their nose or in their mouth into your trachea, and it is attached to your ventilator. Now, the ventilator is the machine that can give a breath to patient who may have trouble breathing or is not able to breathe on their own. So we have two types. I know, I think Ma'am Arsenio already presented to you this one, and already presented to you also in the ICU part, how to properly assemble and set your mechanical ventilator. So this one is already passé to you guys. So assess control mode or your AC volume. What is happening here in assist or control is a mode of ventilation where a minimum number of preset mandatory breaths are delivered by the ventilator, but actually the patient can also trigger an assisted breaths, as you can see here in our illustration. So the patient makes an effort to breathe, and the ventilator assist in delivering the breaths. Okay. So in this mode, the operator can actually set either a controlled pressure or controlled volume. Now, the next one is we have your synchronized intermittent mandatory or your SIMV. The rate and the tidal volume is preset, and this one is to wean the patient from the ventilator. Okay. We also have your pressure support, that is pressure support ventilation. So with this one, this is a mode of positive pressure mechanical ventilation in which the patient triggers every breath. Okay. We have here the patient management respiratory system ventilation, ventilator setting control. We have your FiO2 or your fraction of inspired oxygen, which is the oxygen content all that is inhaled daily that helps the exchange gases in our alveoli level. So typically, our Earth has like 21% of oxygen, but when, of course, we are dealing with patients with respiratory ailment, the FiO2 concentration may extend up until to 99%. However, we just need to keep it until 50% to avoid toxicity. Okay, now for the rule of thumb here, just like what we've talked a while ago, 1 is to 24, 2 is to 28. You will just add 4. Okay. You also have your respiratory rate, number of breaths per minute. You already know this one. 12 to 20 is the normal for an adult. Tidal wave, a number of milliliters of air to be delivered with each breath, like 5 to 10 ml per kilogram. You also have your inspiratory pressure limit and your PEEP, which is the positive and expiratory pressure. Okay. Also have here the sensitivity and then the alarm. Complications of your mech vent, please read this one on the PowerPoint that I've sent to you. We have your aspiration and of course nosocomial. Nosocomial, these are the um, hospital acquired bacteria. You also have your ventilator associated pneumonia, decreased cardiac output, and GI problems, as well as your muscle weaknesses. So, on the next part of our discussion, we will be discussing the common respiratory problems that we're going to encounter in our hospitals. That's it for now. I'll see you again next time.